Hey everybody, how you going? My name's Paul. This is my co-conspirator Sharon. Sharon's going to be doing all the behind the scenes work today, and she's going to drop in and help out when we do our demonstrations. Today, what I'm going to get Sharon to do now is I'm going to get her to put some screens up for you. So we're going to start out with our housekeeping screen. Just a few things we need to go through before we start. So, the session overview. I think today we're doing 001, 003 and 004, which means there's going to be 3 10-minute breaks throughout the day. We'll tell you when each section is finished. So if you're only doing CPR, you're only going to be here for the first hour, and then you'll be able to go off. All right? Please try to have as little distractions as possible. So I know you're going to have your phones, but try to make sure you're in a quiet place so you can concentrate on what we're talking about. Yeah. Please, I encourage you to take notes. When you book in for your 2-hour practical session, you are going to have to do your assessment. Having those notes will help you through that assessment. The trainer will help you through it as well. If there's any questions you have throughout the day, please put them into the chat box. Yeah? Sharon's here to answer your questions. Any really good questions, we'll bring up with the whole group and I'll address it as we go through. If you have any technical problems, call the number on your screen or send an email to webinar@firstaidpro.com.au. When you finish your particular part of the webinar today, please book your practical workshop. Now, the office will call you to arrange that booking with you. They'll give you several options of when you can get it done. You will not get a certificate until you complete your practical session. Yeah. When you go to your practical session, make sure you bring a photo ID with you and your USI number. It's really, really important. They're mandatory. If you're under 18 and you're doing the course, that's great. Just remember to bring your under 18 consent form.
I've released under the handouts tab the quiz, the under 18 form, and I've released the learner's guides for 001, 3 and 4 if you want to download them and you didn't get them.
All right. You'll find those under your handout tab. So click your handout tab, download.
Which is right beside the chat. Oh, and right near that as well is a polls button. Throughout today, I'm going to release a couple of poll questions just for you to answer. It's not about you getting them right. It's about knowing that you're there watching.
They're watching, that you haven't snuck off to do something else, that you're actually sitting there watching me. The other thing is your quiz. It's a pre-knowledge quiz. You must bring it with you when you go to do your practical course. If you can't print it, that's fine. Do it on your phone. Do it on a piece of paper. When you get to the training session, tell the trainer he will give you a hard copy that you can transcribe onto. It's really important that you do it before you come. It shows that you've done your pre-learning. All right, so what we're going to do now is we're going to start. Now remember, we will tell you through each session when you are finished and when you are allowed to go. We'll also go through what you need to bring with you at every break. Okay, so let's get started, Sharon. What are we going to start off with? We're going to start off with our introduction. And an introduction starts off with, what is a first aider? So what's a first aider? A first aider is generally the first response. We're the first person to offer any sort of initial or medical treatment to a casualty before the professional medical people arrive. So who are our medical professionals? A lot of people say doctors and nurses. Yeah, they are. But basically, it's really ambulance officers, paramedics, some firemen, because they're paramedics as well. Doing this a long time, it's unusual for a doctor to turn up at an accident scene. If you're at an accident scene, you call 000. Who rocks up? An ambulance crew or a paramedic will rock up to assist you. So if someone does turn up and claim to be a doctor, check. Make sure they're not a doctor of archaeology, a paleontologist, any one of those. Make sure they're an MD, all right?
You know, the easiest way to check, if they start doing CPR on their knees, they're probably not a doctor.
Yes, if they're not doing it properly, okay? As a first responder, it's your legal obligation to hand over to a medical professional. That's the only way you can relinquish your duty of care and all those sorts of things. But we'll talk about that as we go through. The aim of first aid. The aim of first aid is to preserve life, to protect the unconscious, to prevent the condition from getting any worse. So that's illness or injury. We try to stop it getting any worse. To promote recovery, I think the most important thing we do though is seek medical assistance. No point doing the other four if we forget to call the ambulance. Sharon, take your head out screen. Thank you. So make sure you call that medical. Get them out there, get that ambulance there as fast as possible. All right. I don't know if any of you have ever heard of the Good Samaritan law. The Good Samaritan law in Australia stops people suing us if we inadvertently injure them in a first aid situation. We're in America, rescuing someone, their car's on fire, we drag them out of their burning car, but we twist their knee in the process. They can actually sue us for twisting their knee because we didn't take duty of care. Bit of a strange rule. Here we have the Good Samaritan law. The Good Samaritan law says, as long as I abide by and follow the rules, regulations and principles set out by the Australian Resuscitation Council, all the states and territories of Australia, you can't sue me. No one's ever been sued under the Good Samaritan law. Those rules and regulations are what we call our legals. And our legals are duty of care, consent, negligence, record keeping, privacy and confidentiality. In this section, we're also going to talk about infection control, manual handling and stress management. It's all sort of all in the same thing. So duty of care, what is it? Duty of care is a legal obligation. It's your legal obligation in your workplace. In your workplace, someone collapses on the floor in front of you, near you, you must assist them. Makes no difference if you're the designated first aider or not. You must help. That's it. It's your legal obligation to do so. You are legally obligated to assist clients, co-workers, or anyone that you can reasonably expect to be on your premises. That's in your workplace. Do we have a duty of care to the public? No, we don't, unless you're a medical professional. You're the average person in the street, you're walking down the road and someone collapses in front of you. You do not have to help them if you don't wish to. The choice is yours. Your legal obligation starts as soon as you make the first approach. So someone's collapsed, I walk up, my name's Paul, I'm a first aider, can I help you? By asking that question, by giving them a nudge, I've taken on a legal obligation, I've taken on their duty of care. I've also taken on their rights for privacy and confidentiality. I now have to do first aid to the best of my ability, sticking within the realms of my training, yeah? I have to take all reasonable steps to ensure I cause no further harm, yeah? Remember, I've also taken on their privacy and confidentiality. So my patient's laying on the floor, the casualty, they're awake, they're talking to me, they've given me their life's history, their medical history, they've told me a couple of embarrassing things about themselves. So when the ambulance crew comes, I have to give them that report, a full, frank and honest report of everything the patient told me about themselves, what I saw, how I've treated them, what I've used. I have to hand that over to the ambulance crew. If the police are there and they ask me for a report, now I have to give the police officer a report. But do I give him the same report that I gave to the ambulance officer? No, I don't. The police don't need to know the person's medical history, especially if it's embarrassing history, something like that. Information should be passed on as a needs-by basis, yeah? So the report I'm going to give to my police officer is the person's name, their address if they can't tell them themselves, and what I physically saw myself. All the medical history is not the police's concern. If they want to get that, they can ask the person themselves. I'm not allowed to tell them. So we must always look after our patients' privacy and confidentiality. In your workplace, always follow the policies and procedures set out by your workplace for spreading or giving out information, yeah? Information is a needs-by basis only. Remember it. Okay, consent. It's really simple. I walk over to my patient. My name's Paul, I'm a first aider. Can I help you? If they say yes, it's fantastic. If they nod their head like this, that's okay. That's consent. If I got them on the ground and I squeeze, if you can hear me, squeeze my hands and I squeeze my hands back, that's consent. It's not consent if they physically push me away or verbally tell me to go away in any language they like, yeah? We have a little bit of a quandary here. I'm not going to ask someone if they need help unless I really think they need help, yeah? So I walked over, I said, can I help you? And they said, no, go away, quite aggressively. What do I do? I know they need help, but they refused it. Why could they refuse it? They could be drunk, could be intoxicated, they could be drugged up. not quite in their right mind. I'm going to walk around the corner where it's safe, and I'm going to dial 000, and I'm going to ask for police and ambulance. Why do we ask for police and ambulance? Because ambos don't like getting beaten up. Neither do first aiders, yeah? So always get police and ambulance to attend. If the person gets up and walks off, don't follow them. Tell the person on the phone, give them a description of what the person looks like, the direction they're heading, what road they're on. They will go and get them. You don't follow them. It's not safe. All right? Where there's kids involved, who do we ask? Obviously, we ask their parents, carers, or guardians, if possible. If there's no parent, carer, or guardian there, under the Good Samaritan, we have the right to work on the child. There's no issue. Yeah. Our advice, though, is if there's another adult in the vicinity, get that adult to come over and stand next to you as a witness. Why? Because that's the world we live in. Yeah. Make sure you have a witness if you can. If there's no one else around, you have the right to work on them, so work on them. 99.9% of kids don't lie, but you only need one that does, and it makes your life a misery for the next 6 months. All right? Remember, if the person's unconscious, I don't have to ask for consent. Problem is, I don't know they're unconscious until I actually ask the question and they don't respond. So, as part of the system, as part of your plan, always ask. It's just common sense. All right? Okay, negligence in first aid. It's another one of our legals. Negligence in first aid is doing anything you're not trained to do. Jim's laying there on the ground. That's my casualty. His name's Jim. He's laying on the ground. He's got an open fracture of his right leg. You walk up, grab his ankle, manipulate the bone back into place. Can you do that? I hope you all said no. Why? Because you don't know how to do it. You may damage arteries, nerves, tendons, yeah, all those sorts of things. You may actually make it a lot worse. Also, no matter what you see on the television, don't go around giving people tracheotomies. It's not as easy as it looks on the television. So that's negligence. Stick within what you know. You're talking to an expert on the phone. You don't know what to do, you're not sure what to do, ask, they'll tell you, yeah? That's why they're there. Never hang up on them. All right, record keeping. You're in your workplace, you've had an incident. Everyone knows what we have to do. We have to go and do an incident report. We then have to do a risk assessment. If it's in a childcare centre, we're going to have to get a CPR involved. If it's a child and they've been injured in your care, you must keep their records confidential and you must keep them until the child is 25 years old. We don't have to keep our tax record for 7 years. All right? So that's in the workplace. In the public, I've worked on Jim for 10, 15 minutes. The ambulance has arrived. What did I say earlier? I have to give them a full, frank and honest report of what I've done. Yeah? That's what I have to do. Same reports to the police? No, I only tell the police what they need to know. So that's what we have to do. What else should we do? We've handed over to our ambulance, we've handed over to our police officer. Now what I do is I get my phone out. I write myself an email. Everything I did, everything I saw, everything I used, everything that's relevant to what happened, and send it to myself. Why? Because if the incident was a result of an altercation between two people, it may end up in the courtroom. Who's going to call as a witness? They're going to call you as the witness. Do you want to sit there in the courtroom and ask you a question and go, yeah, I'm not sure what I did. Oh, hang on, I've got my notes. If you wrote it out directly after the incident in a court of law in Australia, it's considered gospel. No one's going to accuse you of lying. If you don't have a phone, pen and paper, write it on pen and paper. Yeah, get someone at the scene to witness it for you. If the person died, it's going to end up in the coroner's court. Same thing's going to apply. They're going to ask for you to be a witness. Now, most people that get involved in something like this, if it's the first, second, third time you've done it, it could be a life-changing episode for you. Most people don't want to remember it. They'll remember the incident, but they don't want to remember all the gory details. And courtrooms want detail. That's why you write it out. All right? So we're still at the end of the scene. We worked on Jim here for 20 minutes. Unfortunately, Jim didn't make it. All right? What are we going to do? If we can, look after Jim's dignity. Cover him up so no moron can take a photo. Yeah? So always cover the patient up, casualty up if you can. Now, I need you to then look and think about yourself. Take part in any debriefings, any evaluation sessions. Seriously put steps in place to look after stress management. We don't want first aiders coming down with post. traumatic stress disorder, yeah? It's really important that you look after yourself. If you know a friend that's gone through something like this recently, go and ask them if they're okay, because the effects may not happen straight away, they could happen later on, yeah? So always ask that question, look after yourself, it's really important. Infection control. Now, infection control is quite easy. I'm just going to put this down for a second. So, infection control. All states have regulations. We'll talk about those regulations. But, basic infection control. Wash your hands if you can. If you can't wash your hands, use 99.9% hand sanitizers if you can find any. All right? So, rub the hand sanitizer in, put gloves on. Get a face shield. Yep, I have one in my pocket. Get a face shield and glasses. Now, if you don't have specs like I've got, wear your sunglasses, they work just as well. What are we trying to do? We're trying to stop any errant fluid splashing on my face, getting on my hands, yeah? A lot of people are going to say, oh, well, I'm not going to have gloves with me. Well, really, you should have, if you had an accident scene, hopefully in your car you've got a first aid kit. There'll be gloves in the first aid kit, so always make sure you put them on. If you've got nothing, yeah? Your skin is a natural barrier to infection. If you have no open cuts, abrasions or grazes on your skin, you are unlikely to get infected. But the key word there is unlikely. Always put gloves on if you've got it. Anything you can put between yourself and someone else's bodily fluids is a great idea. Now, in my car, I have a roll of cling wrap, so I wrap my hands in cling wrap. Most cars have shopping bags in them. Use the shopping bags, that'll do. If you're doing CPR and you want to do breaths and you've only got a chip packet with you, use the chip packet. Put a hole in the chip packet and use that. It's not ideal, but it's better than putting your mouth around them. Yeah? So use what you've got. Be a little bit inventive. Alright? So that's our infection control. Manual handling, why is it important? It's important because I don't want you to hurt yourself. Where possible, and I state where possible, we always start on the right hand side of our patient. Our patient's right, not ours. Why the right? Because good manual handling technique is I'm going to roll away from myself. I never roll towards myself. Now, it has an added bonus. If I roll towards myself and the patient vomits, where's the vomit going to go? It's going to go all over my legs. Nah, don't like vomit. That's why I roll away. If they vomit, it goes the other way. The other reason we stand on the right is because the recovery position's on the left-hand side. We always roll people to the left-hand side. Why the left? It's not got to do with the heart. A lot of people think it's got to do with the heart. It's got nothing to do with the heart. It's got to do with pregnant women. If you put a pregnant female, if she's 3 months pregnant or more, if she's unconscious and breathing, and you roll her onto her right-hand side, the weight of the baby in the womb can crush the major arteries leading to the lower limbs. It can paralyse the female. It can also kill or damage the baby. So the reason we say all people on their left is because if I stood up here and said, men can go on their right or left, doesn't matter. Women can go on their left, have to go on the left if they're pregnant, but they can go on their right if they're not pregnant. It's too confusing. Everybody goes on the left-hand side, yeah? The only time I put a male on his right-hand side, if he's bleeding out of his right ear. If he's bleeding out of his right ear and it's clear and sticky, it's cranial fluid. It's got a fractured skull. If I put him onto his left, it's going to pull in his ear, cause pressure in the brain and cause brain damage. Leaves me with a quandary. What do I do with a pregnant woman that's bleeding out of her ear? What do? I leave her on her back. I put a clean cloth under her ear to collect the discharge, and I do what we call ladder left or right height. I get a blanket, a cushion, a pillow. Now, if you don't have one of those, a handbag, a backpack, your sneakers, your jumper, anything, and put it under her right hip. What does that do? It tilts the body to the left, takes the pressure off the major arteries. The biggest difference is if the man is laying on his right-hand side and he vomits, there's no issue. If the female is laying on her back and she vomits, I need to be there 100% of the time to make sure she doesn't aspirate, so I can roll her over quickly and clear her airways. All right? The other thing with manual handling is, how do we move someone? All right? We're in an accident scene. It's really dangerous where they are. Now, my patient Jim weighs 85 kilos. He's laying on the ground. There's two ways I can move him. I could do the one-man drag. So squat down in front of him, squat down, sit him up, put my arm under his armpit, grab his wrist. Put the other one under, grab his wrist, hold him nice and tight, stand up. Now, the problem I have with that is most people I know can't squat 85 kilos. Most people have trouble squatting 60 kilos. Think about it. Can you squat 85 kilos? When you pick him up, if he has internal injury, you'll squeeze him quite hard. It's not a great idea. What does his head do when you pick him up? Drops forward. Can he breathe? No. If he's got any back or neck injuries, you've made it worse, possibly. So what am I going to do? The best way to move someone is step over them, pick up their ankles, and walk off. Yeah? People say, that's terrible. His head's going to bounce on the ground. Do I care? We're in an emergency situation. Where he is dangerous. If I leave him there, he's going to die anyway. If I drag him 20 metres, he gets a bump on his head and a scratch on his back. If I revive him, does he care? No. And if I don't revive him, he doesn't care either. So it's a win-win situation. A little bit of common sense though. If you're 2 floors up in a building and you need to move someone, don't drag them by their ankles down the stairs. Can you imagine? Bonk, 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 bonk. 2 floors. If he wasn't dead at the top, he probably would be dead at the bottom. When we do this at Northvale, one of our training centres here in Adelaide, a student said to me the other day, oh, I'd just pick him up and chuck him over the rail because we're on the 1st floor. That sound like a good idea? It's not really, is it? Because the stop is pretty bad. 1 floor up. So why would you throw him over the rail? He said, oh, it's a quick way down. Fair enough, it is a quick way down, but not ideal. All right, so we talked about our duty of care. We talked about our privacy and confidentiality and our stress management. What I'm going to do now is we're going to talk about our workplace procedures. So, workplace procedures. The ARC, the Australian Resuscitation Council, is the leading body with everything to do with the rules and regulations around first aid. But the ARC doesn't work in a vacuum. They work with a lot of other clinical bodies to come up with these rules. They don't come up with them all themselves. I could stand here all day and talk about all the different clinical bodies. I'll just give you a few. So, the ARC, they get additional information from the Heart Foundation, the Diabetes Foundation, the Stroke Foundation, and the Anaphylaxis Foundation, and also the burn centres. All of these people have an input into the decisions that the ARC, the Australian Resuscitation Council, make. So that's the difference. All right? Okay, state and territory regulations, first aid codes of practice. All states and territories have their own rules and regulations. Most of us are all the same. The Northern Territory is a little bit different in a couple of areas. In the Northern Territory, if someone collapses on you, you are duty bound, under duty of care to assist them. You have no choice. In the Northern Territory, if you do not assist, by statute, you can get up to 7 years jail, and I think the fine's about $100,000. So it's quite an onerous sort of thing. What constitutes assistance? Assistance is as little or as much as making a phone call. As long as you make that phone call, you met your legal requirement, yeah? If you're driving between Alice Springs and Darwin, come across someone laying in the middle of the road, in the middle of nowhere, do you have to stop and help them? Well, the law says you must assist. There's also signs up saying don't stop. It's deemed to be too dangerous to do so. So how do you meet your legal requirement? You make a phone call. If you can't make a phone call with your normal phone, I'm using my phone, I don't have any signal. I'm going to try 112. If I dial 112, what does it do? It links me to the next available carrier. So if you're out around Katherine, 15 minutes outside of Katherine in the Northern Territory, the only signal you're going to get is a Telstra signal. So if you're with any other provider, you go to do a phone, you're not going to get anything. So dial 112, it'll link you to Telstra or the next available carrier. If you still can't make a phone call, you are legally advised to go forwards or backwards to the nearest town and report it to a responsible person in that town. All right? That's the Northern Territory. Now, the other rule and regulation that everyone has is that you must take all reasonable steps to ensure you don't spread infectious diseases. That's why we follow our basic infection control. Gloves, face shields, glasses, yeah? Stops the spread of infectious disease. So make sure you do it. The other rule that everyone else has is, as a first aider, you are not allowed to administer medication. You are allowed to assist with medication. So we'll talk about assist when we get to the heart attack section, yeah? So assisting with medication is what we're allowed to do. The only 2 medications you're allowed to actually administer as a first aider is an EpiPen or an asthma puffer. Those 2 you can administer. Everything else, You must have prior approval in either written or verbal from the casualty, parent, carer or guardian if you're dealing with a minor. Your first aid currency, you need to do your CPR every 12 months to keep your qualification. And a lot of people don't do it every 12 months. That's fine until something goes wrong. Someone has an incident, someone passes away, WorkSafe SA, someone's going to come and investigate. They're going to ask, who's the first aider and where are their certificates? Yeah. So be sensible, do it every 12 months. Now, your provide first aid or your old senior first aid needs to be done every 3 years. Same as the childcare certificate, every 3 years. All right. Safe work practices, risk assessment, standard precautions. Well, we talked about our standard precautions already. Wash your hands, put your gloves on, face shield and glasses. So there's our standard precautions. Risk assessments. I'm standing on the edge of Highway 1. Traffic's going backwards and forwards like crazy. Someone's laying in the middle of the road. They've been injured. Do I run out and help them? No. What I'm going to do first is I'm going to stop and think, which means I'm doing an internal risk assessment. Yeah. Never rush in without thinking about it first. There's lots of cases over the last few years where people have blindly ran into a situation and have been killed or injured in the process. If they'd stepped back and thought about it for a few minutes or a few seconds and then did it, they'd probably be okay today. No doubting their courage, maybe their common sense. Always stop and think and do that risk assessment first. Consent for adults and minors we've talked about already. So always get consent where you can. When it's minors, always ask a parent, carer or guardian. They're not there, you have consent to work on them. Respectful behaviour. How do we show respect? We show respect by always getting consent. We never yell at casualties. We're not judgmental. Even if in the back of our head we think, oh, we probably deserve what happened, we still don't do it. Yeah, we stay absolutely non-judgmental. And really, when you think about it, no one deserves really to get injured. Yeah, so think about it before you do it. Always, when you're dealing with someone, if they're conscious, ask them their name. Why? Because it builds a rapport, makes the person feel safe. What else does it do for you? It tells you what their cognitive ability is. If they can't tell you what their name is, there's probably a problem. They've got a head injury, something like that. So it gives you a clue of what's going on. All right. Know your own skills and limitations. That way you won't get sued. Remember, don't do anything you're not trained to do. You're not trained to do it, don't do it. Ask the person on the phone. They'll explain what's allowed and what isn't. Verbal and visual assessments. How and why? Okay. I've got my person, my casualty laying on the ground. Jim, he's conscious. Jim, where's it hurt, mate? I've got a really sore arm and my leg hurts. Any other places that you hurt? No, everything else seems fine. Okay, I've done my verbal assessment. Yeah. Visual assessment is used for someone that's not quite so coherent. They could be unconscious, they can't answer your questions. What I'm going to do now is I'm going to do what's called my secondary survey. I'm going to start at the top and I'm going to work my way all the way down through the body. It's not squeezing, poking, pulling, dragging. It's just gently feeling all the way down. What am I looking for? Broken bones, contusions, abrasions, lacerations, those sorts of things. Now, how do I say this nicely? Don't linger where you're not meant to. Yeah? You have to check, yes, but don't linger where you're not meant to. All right? So, we'll move on a bit further now. What are we going to talk about? People become unconscious. Most of the people that we're going to deal with could possibly be unconscious. So it's a good idea to know what causes people to go unconscious. So low oxygen levels, hypoxia, aquatic hypoxia, yeah? Fainting, abnormal heart conditions, trauma, brain injuries, strokes, tumours, epilepsy, those sorts of things, and overdoses, drugs, alcohol, low blood sugar or hypoglycemia, all of those sorts of things can cause unconsciousness. So we come across someone, they're unconscious, they're not breathing. No signs of life. What are we going to do? We are going to follow our basic life support chart, which is our doctor's ABCD. If we come across someone that's unconscious and they are breathing, we're going to put them into the recovery position. Remember, the recovery position's on the left-hand side. What do we do when we get to an emergency? It's really important. Said it already, but what do? We quickly assess the situation. Do our risk assessment. Think, before you act. It's really important. I'm going to ensure it's safe for me, the bystanders, and then the casualty. Why in that order? Because if I get injured, I can't work on the casualty. How many people can I work on at once? One. That's why I don't want the bystanders injured. Why is the casualty last? Unfortunately, he's already injured. So we can't really about that until we make sure it's safe for everyone else first. And remember to call the ambulance. It's really, really important. Now, we're almost to the point we're going to start doing CPR. So what is CPR? It stands for cardiopulmonary resuscitation. CPR does exactly the same thing as a life support machine. What does a life support machine do? Oxygenates the blood and circulates it. What does CPR do? Oxygenates the blood and circulates it. What are we trying to keep alive? A lot of people say, oh, the heart, lung, liver. No, they'll look after themselves for a reasonable length of time. We want to look after the brain. The brain, once the blood stops flowing and the oxygen stops being supplied, brain damage starts between 4 and 5 minutes. So if you start CPR 10 minutes after the person became non-responsive, they've had 10 to 11 minutes of brain damage. They're not going to be the same person. They're going to have lots and multiple issues. They may have to learn how to talk, learn how to walk, learn how to feed themselves, all those sorts of things. So the idea with CPR is to get in there as fast as possible. Always do your DRS, ABCD, but get started as fast as you can. So what we're going to do now is Sharon's going to bring up our primary secondary survey screen, right, which is our DRS ABCD. So there we go. Right, it's up on the board. So what have we got there? First thing we're going to do is look for danger. When I look for danger, I look up, I look down, I do a 360-degree look around me to make sure it's safe before I start. If it's not safe, I have a choice. I can move the person to where it is safe, or I can just walk off and not do it at all. Yeah? So I've checked for danger, had a good look around. What's dangerous? Electricity, yeah? Fire, smoke, fumes, chemicals, spills, falling debris. People, we have more trouble with people than anything else. The person, the casualty laying on the ground, are they dangerous? Yeah, they are. We're all programmed by nature with fight or flight response. Jim's laying on the ground, he's been knocked out, doesn't know what happened, and suddenly he wakes up with a stranger looking at him. His first response might be to lash out and have a go. So always remember the person on the ground is dangerous until you know better. Okay? So check for danger, we're going to check for response. What do? We tap with the back of the hand on their ankle. Tap, tap on the ankle. Why do we tap, tap with the ankle? Because Jim's been whippersnipping his hedge in the front yard. He's laying on his extension cord. It could possibly be live. If I touch him with the back of my hand, the electricity throws my hand backwards, closes my fist. I don't get injured. I can now go turn the power off, yeah? If I grabbed him, I would be stuck and be electrocuted as well. I can't let go. I always touch him back of the hand. Walk up, clap your hands. Hey buddy, can you hear me? My name's Paul, I'm a first aider. Can I help you? I'm not getting any response. I'm then going to go down and I'm going to grab his hands. If you can hear me, squeeze my hands. Why don't I squeeze his hands or ask him to squeeze mine? The reason I do so is because, what? I grab both hands because if he's had a stroke, a brain injury, something that's impeding the use of both sides of the body. By checking two hands, I'm checking both sides of the body. The secondary reason I grab both hands is because if he suddenly comes to and is a bit unruly, who's in control? I am. I can talk to him while I control him and he can't hit me, so that's really important, yeah? In this case though, Jim's conscious, he's opened his eyes and he's looked at me. So I asked the question, hey, my name's Paul, I'm a first aider, can I help you? Yeah, okay, what's your name? His name's Jim. All right, Jim, what happened? I got hit by a car, okay. Sharon, can you call the ambulance for me?
Yep.
Yeah, call the ambulance for me. Now, the reason I asked Sharon to do it, we've got 25 people in the room, let's say. What I don't do is I don't go, somebody call me an ambulance. Why? Because all 25 people are going to call at the same time, or no one's going to call, because everyone assumes that someone else did it. So pick a responsible person, someone you think looks responsible. Make sure they say yes, okay, something to show you that they have understood what you said. So Sharon, call the ambulance for me, then come back and help me.
Okay.
Right, I got mine. The reason I do that is because if Sharon's just nodded her head at me like this, it could be her partner laying on the ground and she could be in shock, and that's what this is, yeah? So always get that definitive answer. So Sharon's called the ambulance for me. What am I going to do now? I'm going to do that head to toe inspection, yeah, my secondary survey. So head to toe, checking all the way down. Remember, don't leave it where you don't need to. While I'm doing that, I'm going to ask a few questions. So Jim, what are your signs and symptoms? Oh, I've got pins and needles in my hands and I can't feel my legs. Okay, I'll note that. Sharon's back now, so she's going to write these notes out or record them for me. Jim, do you have any allergies? Oh, what does that mean? Well, mate, are you allergic to penicillin, aspirin, anything like that? Yeah. I'm also going to ask him if he's taking any medications. When I ask about medications, I'm not asking for the clinical name on the box. I want to know what the medication's for. So Jim's currently taking medication for high blood pressure, heart disease, diabetes, epilepsy, any of those, yeah? Sharon's noting it down for me. I also asked Jim if he's got any past medical history. What do you mean? Well, have you had a stroke recently, a heart attack, a seizure, anything like that? Because a car accident could bring that sort of thing onto you. So make sure you ask those questions. We're also going to ask him when's the last time he had something to eat or voided his bowels. And then we're going to ask him what actually happened. Now, he told me he got hit by a car, but I can't see a car anywhere. So I'm going to get some further information, yeah? I'm also going to ask his full name, his address, contact numbers, relatives. Any information I can get from him is fantastic. That information can all be passed over to our ambulance crew when he arrives. The other advantage of doing this is it takes Jim's mind off the incident and off his injuries. It's giving him something to do while he's talking to me. It builds that rapport, makes him feel a lot safer, right? So it's really important we do our secondary surveys. And Sharon was going to bring that up, put a circle around that sample for us so you can see what I was talking about. So you can do our fancy circles.
It's better than yesterday.
Yeah, look at this. There we go. That's what we were doing. We were doing our sample. So what did we do? We did danger response. We got a response. We obtained some history, sent for assistance, and then did our sample. So what we're going to do is we're going to do it again. We're going to do danger response. Okay, this time I've got no response. So let's put our mannequin down. Yeah. All right. So I've checked for danger. I've checked for response. I've got no response. What am I going to do? Sharon, call an ambulance and go get me a defib.
Yep, done it.
All right, so there's my patients back there like that. So I've sent for my assistance. So I've done danger response, sent for help. What I'm going to do now is I'm going to check his airways, yeah? When an adult's laying flat on the ground, their airway's closed, yeah? So, closed airway. We never tilt the head when we check the mouth to see if there's something in there. The reason we don't is if he's got an all-day sucker in his mouth, chewing gum, false teeth, loose teeth, anything like that, if I tilt his head, I open the airway, and that object could go down his throat and choke him. If I was dealing with a child, in this case, I would definitely look for loose teeth. It's very common for children to dislodge their teeth in an accident situation, all right? So I'm going to check. I'm going to hold his head flat with my hand. I'm going to pull his mouth open. There's something in there. I'm not going to worry about the fancy recovery. I'm just going to put my hand under his neck to support him. I'm going to roll him over. I'm going to grab his hand and I'm going to clear his mouth out, yeah? Now, if I can't use his hand because it's damaged, I'm going to massage it out through his cheek, like that. Massage it out through the cheek. It should have dropped into the cheek, so it's easy to get out, yeah? Massage it out, sweep it out, there we go. Now, I've checked his airway. And remember, if I'm working on a child, if he's got any chest or abdomen injuries, it's more than likely going to impinge on multiple organs, so I need to be a little bit careful. We've checked his airway, we know it's open. What we're going to do now is we're going to do our look, listen and feel. Now, look, listen and feel. Why am I doing it? I want to know if he's breathing. We do CPR on people that are unconscious and not breathing normally or not breathing at all. That's when we do CPR. That's the only time we do it. So, I've checked his airway. I'm going to tilt his head back. I'm going to open his mouth. Right? I'm going to put my hand Right there, it's under the breasts, under the pec muscles, on the bottom of the diaphragm. Right there. Put my head down by his mouth and look, listen and feel for 10 seconds. Yeah? Okay, Jim's breathing normally. So what I'm going to do, I'm going to put him into the recovery position. So Jim has just suddenly turned into Sharon. Hello, Sharon.
Hello.
She's unconscious, but she's breathing normally. I'm going to put her in recovery. So left arm goes up, right arm goes across the chest. When you pick the knee up, pick it up from under the joint, bring it up to there. Put your hand under the neck and shoulder to support the neck, on the hip, not on the knees, on the hip, and roll to the center. So we've got it there. You notice the leg drop down on its own. Just move the leg into the right ankle position, put the arm down, tilt the head back, open the mouth. That's our recovery position. Thank you very much for that. So Sharon's laying there. What am I doing? Every few minutes, I'm going to do my look, listen and feel. So what am I doing? I'm monitoring my patient. You right there? Yeah, I'm going to monitor my patient. After a couple of minutes, he stopped breathing. I'm not a doctor. The reason I have to monitor him is, as I said, I'm not a doctor. I don't know why he's unconscious. No idea. Just because he was breathing when I called the ambulance doesn't mean he's going to be breathing when the ambulance arrives. In this case, he stopped breathing, so I'm going to put him back on his back and I'm going to start my CPR. Now, CPR works in 40 to 45% of the cases. A lot of the time, CPR doesn't work because people don't push hard enough. Yeah? You need to collapse 1/3 depth of the chest. If you're not collapsing 1/3 of the chest, you're not doing anything. Yeah? I'm that wide, you're going to make me that wide. What are you doing? There I am. Lungs are here, heart's here. When you push in the first bit, my lungs have air in it. You've now squashed them, the air's been expelled. My heart's full of blood. Yeah, hopefully. When you squeeze, you push all the blood out. The valve opens, the blood goes out. When you open back up, the heart fills up with blood, the lungs fill up with air. When you do it again, you're doing the reverse, and that's what you're doing, yeah? It only works if you do it all the way. On an adult, it's anywhere between 5 and 6 centimeters of depth, which is a fair way down. So we always start in the center of the chest. That's where you start. Adults and children. Baby's the same position, but you don't use your hand, you use 2 fingers. So run your hand up to the armpit, right there. Bring it across to the center, that's the correct spot. My finger should be pointing at the armpit, yeah? My thumb should be pointing to the center of the nose, that's the correct spot. If you're a centimeter down or a centimeter up, it's not going to make any difference. Just make sure you're there. Think about a cardboard box. If you have a cardboard box and you push it to the center, it goes up and down. If you stand on the edges of the cardboard box, you can't get it to go down. The only way you get it to go down is across the chest. If you put your hand like that, you're emulating a cardboard box. The only way you'll get the chest to go down is to crush it. Your hand needs to be there, right? It's really important that it's there. So, the head is always tilted. The mouth is open. Now, in a real person, it'll stay there. It doesn't here because the mannequin's spring-loaded. If you're having difficulty though, take your shirt off, take your jumper off, get a towel, something, put it under the neck to hold the head in that position. In that position, the airway's open. So as soon as I start doing this, he goes on his own, and I don't have to do breaths. For adults, we do not have to do breaths if we don't want to, because his airway's open in this position, yeah? Now, if I'm not doing breaths, it's 100 to 120 compressions every 2 minutes. If I am doing breaths, it's 30 compressions, 2 breaths, 5 times every 2 minutes. We always start with compressions. We never start with breaths. The blood has oxygen in it. In this position, as soon as I start, he starts to breathe on his own, and he's oxygenating the blood. So we're going to start, hand up to there, to the center, knees apart, roughly same distance as my shoulders. Elbows locked in, leaning forward, using my body weight, not my arms. If I do that, I'm going to wear out very quickly. So it's nice and tall. You know? So twinkle, twinkle, little star, staying alive, a little bit inappropriately, another one bites the dust, and if you're really, really desperate, baby shark.
No, exactly.
Now I've locked in like that. You can also lock in like that. right? Whichever one suits you, whichever's comfortable for you. And then we go. So I'm going to do breaths. I've got my mask. Get my mask. Put the mask on the mannequin, like that, on the person. Pistol grip the chin, under the mask, not on top of the mask because you can't spread the plastic. So under the mask, right on the edge of the chin. Pistol grip, pull the mouth open, squeeze the nose. Adults and children, you must squeeze the nose. If you don't squeeze the nose, when you blow in the mouth, the air will come out the nose. Arm down, under the mask, pull it open. Take a big breath. Turn your head, take another deep breath. Okay, take the mask off and start again. All right, so I'm whacking away. Sharon.
I've got the G-fit.
Okay, great.
How are you feeling? Do you want me to take over for a
No, I'm getting very tired. I'll put the G-fit on, you take over, okay? So, 5, 4, 3, 2, 1, take over. So Sharon's taking over, that's our straight changeover. Now I've got my G-fit, so what am I going to do? First thing I'm going to do is I'm going to open the bag. Now, G-fits come in all different shapes, sizes, all different sorts. First thing we do is look at what's in our kit, take everything out. It's going to have a pair of gloves. It's going to have a face shield. It's going to have a pair of scissors and a razor blade. The scissors is for cutting clothing. If you're working on a female, you need to remove the bra. Cut it in the centre, pull it off, yeah? The razor blade is for men with hairy chests. Don't shave first. Put the pads on first. If the machine says, make good connection with patient's chest, their chest, take the pad off, shave where the pad goes on. No manscaping, yeah? Look at your machine. That's what it looks like. Some of them, they're all different shapes, as I said. Some of the new ones out in the public have a switch on them. The switch will have pediatric or adult. You don't need to know the voltage, you only need to know that if you're working on a 1 to 8 year old and it has a switch that says adult pediatric, you put it to the pediatric switch. If it's an adult, you put it to the adult switch, right? So first thing to do, turn it on. Now, look at my pads.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
A lot of the machines in the public domain do not have 2 sets of pads, they only have 1 set of pads.
Apply pads.
And that's
Plug in connect.
And that's the adult pads. The pads underneath are the pediatric pads. If your machine has pediatric pads and you're working on a 1 to 8 year old, they are the pads you would use. They go, draw an imaginary line between the nipples. It goes in the centre of the chest, half above the line, half below the line, and the other pad goes on the corresponding position on the child's back. If you have pediatric pads. If you don't have pediatric pads, you're going to go adult pads, and you're working on a 1 to 8 year old, in exactly the same position as the pediatric pads, front and back. Always for a 1 to 8 year old, regardless of your machine, regardless of pads, it always goes front and back. Now Sharon must be getting pretty tired on that. So turn my machine on. Okay.
Apply pads to patient's bare chest.
Okay.
Plug in pads connector next to flashing light.
The next one. Under the breast, roughly 1 thumb under the breast or pec muscle.
Apply pads. Plug in connector.
Plug my connector in.
Analyzing heart rhythm. Do not touch the patient.
They clear.
There.
Shock advised.
So the heart's doing this.
Charging. Stay clear of the patient.
Second warning.
Deliver shock now. Press the orange button now.
Now you can see the orange button flashing there, yeah? Before I push the button, I'm going to go clear there, and then I'm going to push the button.
Delivered. Start CPR.
Oh, he's vomiting.
He's vomiting.
Oh, he's breathing. We
Right.
can take the defib off now, can't we?
No. Once you put the defib on, you never ever take it off. You never turn it off. The only one that turns it off or takes it off is the medical professionals when they arrive, yeah? Always leave it on. You don't know why his heart stopped or why it went into a shockable condition. 5 minutes after you started, he may conk out again and then you've got to do it again. The machine's on. Always follow the directions of the machine. All right, thank you very much. With an adult, remember, it goes upper right, lower left. Under the clavicle on the right-hand side, under the breast or pec muscle on the left-hand side. There we go. Give you a child, 1 to 8-year-old, just so you can see it on the child. They go imaginary line between the nipples. It goes half above the line, half below the line, and in the corresponding position on the back. Yeah, so front and back on a 1 to 8-year-old. On a baby from 0 to 12 months, you cannot use a defibrillator. 1 to 8, front and back, regardless of what machine you have, what size pads you have, adult or pediatric, it always goes center and back. Adult is always upper right, lower left. Now, people ask me, is it okay to use a defib on someone that has a pacemaker? There's no problem. The pacemaker normally sits on the left-hand side of the chest. It's about the size of an old-fashioned sweet tin. It's quite clearly visible with a scar running off it. The pad is on the right-hand side, so there's no issue. If you have someone that has 2 pacemakers, it's unusual, but it does happen. Never put a pad on top of a pacemaker. You would put it in the center of the chest. If you're dealing with a 1 to 8-year-old that has a pacemaker, the pacemaker is under the ribs on the left-hand side, so it doesn't interfere with the pad. All right. There's no problem using a defib on a pregnant woman. There's absolutely no difference. Yeah. Do exactly the same thing. CPR on a pregnant woman is 30 compressions, 2 breaths, 5 times every 2 minutes. Makes no difference. Yeah. The machine will not pick up the baby's heartbeat. So, babies. Here's our baby. Baby's physiology is completely, now it's easier. Baby's physiology is completely different to an adult. When an adult's laying in that position, his airway is closed. A baby from 0 to 12 months laying in this position, his airway is open. If I tilt his head back in that position, I've closed his airway. I can blow as much air as I like, I will not get air into this child. Babies, until they're almost 12 months old, approximately, they will mature slightly differently. They only breathe through their nose. Yeah. So when we're doing breaths on a baby, we don't call them breaths, really, we call them puffs. Yeah. It's as much air as you can hold in your cheeks. That's it. My lungs hold 3 litres, his hold approximately 500 ml. If I blew into him like I blew into the adult, I would damage his lungs severely. So it's a puff. So make a perfect seal around the nose and mouth. So the baby's laying flat. Put the mask on. Make a big seal, big wide mouth. Turn my head, take a big breath. And that's it. That's 2 puffs. So babies are still 30 compressions, 2 puffs, 5 times every 2 minutes. Now, baby, until he's 12 to 18 months, his tongue is too big for his mouth. As an adult, if you're laying on the ground and you're unconscious, the most likely thing to block your or obstruct your airway is your tongue. You can still breathe around it. It makes a horrible noise. Remember, the more noise they're making, the more air they're getting. With the baby, if I tilt his head back like that, it blocks his airway completely. The tongue will drop on top of the trachea and block it as effectively as putting a lid on a jam jar. You'll get no air in. Babies must be done in the neutral position. Baby's carotid cartilage sits here. It's not properly set yet. If you tilt the head back, you can damage the carotid cartilage, restrict the airways, break the neck, all sorts of things. Baby's trachea itself is really important. It's shaped like a funnel. It's very short, it's very narrow. It's much easier to block than it is in an adult and an older children. Remember also, baby's head is predominantly larger than an adult's. Remember that if they're in an accident, the likelihood of head trauma or brain damage is much more likely because the brain's going to bounce around. All right, babies, you still have to do compressions. Still 30 compressions. Run your hand up to the armpit, bring it across to the center of the chest, keeping your fingers in the upright position. Don't lay them down beyond the rib cage. Nice and straight. 30 compressions, 2 breaths, 5 times every 2 minutes. Same thing. Babies, we still have to do our DRS. There's no point tap, tap, tap. If you can hear me, squeeze my hands, doesn't work. Babies all have the same response unless they have a neurological difficulty. If I put my finger in a baby's hand, he should squeeze it. If he doesn't, I rub his palm, he curl his fingers up. That doesn't work, rub his foot, it should curl his toes up. Didn't get a reaction, check his mouth, do my look, listen and feel. If he's not breathing, I'm going to start doing my compressions. Now baby's vomits it after 10 minutes, I'm going to roll him over, clear his airway out, yeah, and then I'm going to put him into the recovery position. So recovery position for baby, grab the chin, not the neck, grab the chin, lower your elbow, lift the inside leg, put it on your arm, roll him over, put him up here. That's the recovery position for a baby. In this position, I can hear his heartbeat on my wrist, I can hear him breathing, so that's how we do it, all right? Okay, so let's move on. We've talked about our pregnant women. If we come across a drowning person, what do? If it's safe, get them out of the water straight away. Roll them on their back or side, continue on with your DRS, ABCD, yeah? So, verbal reports, or when do we stop CPR? Good question. We stop when our person responds or begins to breathe normally. Not a big believer in breathe normally. More in response. Non-responsive people, when you're doing CPR, don't move. Any body part moves that I didn't move, they're responding. Stop doing CPR, do your look, listen and feel. If they're breathing, put them in recovery, yeah? All right. If your patient vomits while you're doing CPR, it's a great sign. Non-responsive people don't vomit. Roll them on their side, check their airways, make sure they're breathing, leave them there, yeah? Don't put them on their back and check them again. Just leave them on the side. You can also stop if it's impossible for you to continue. I'm exhausted, it's 40 degrees, I've done 25 minutes. If I keep going, I'm going to have a heart attack or stroke. I can stop. Stop when the healthcare professionals arrive to help you. Now, stop when they come and talk to you, not when the ambulance pulls up, yeah? And stop if it's not safe. If it's not safe, you have a choice. You can move them to where it is safe, or you can stop them. We don't want first aiders injuring themselves doing first aid, all right? Okay, verbal reports. We talked about our verbal reports. Why do we have to do them? Because the ambulance crews, paramedics need to know what we've done. Who to? Ambulance crews or paramedics, quite simple. Always be accurate. Try to be as actual as possible. Don't make things up. Don't embellish it. Remember, always do your verbal or written reports. If you're in a metropolitan area, it's probably going to be a verbal report. If you're in a country area, it may be a written report. Why? In the metropolitan area, 16 to 20 minutes, all being well. In a country area, I may have to look after a person for an hour or more. During that hour or more, I'm going to be checking their temperature, what their breathing's like, whether it's shallow, whether it's rapid, whether it's noisy, whether it's not, whether they're in and out of consciousness, what's their skin colour, all those things. Right? That's what I'm going to be looking for. Now, always remember to participate in any debriefing or evaluation sessions and know your own skills and limitations. Don't do anything you don't know how to do. You're talking to an expert. Ask the question if you're not sure. All right? What we got now? We've got our chain of survival. Early access, early CPR, early defibrillation, and early advanced medical care. What does it mean? It means early access. Get the ambulance there as fast as possible. But always do your DRS first, yeah? North Terrace here in Adelaide, homeless person laying in the doorway, freezing cold mornings, wearing shorts and t-shirts. A bystander walking past, looks at him and thinks, oh, he looks really bad, calls the ambulance goes out and the guy's asleep, yeah? That's the what you feel. He should have done his checks first. Early CPR, we only do CPR on people that are unconscious and not breathing normally, or unconscious and not breathing at all, which is non-responsive. If we have a defibrillator, we put it on straight away. Danger, response, send, airways, breathing. Not breathing normally, not breathing at all, put the defib on, yeah? They work really, really well. And don't leave your patient to go and look for one. Start CPR, get someone else to go and get it for you. And the quicker we can get them to advanced medical care, the better. All right.